we are live. It is Thursday night. Thank you so much for joining us. We have the wonderful Jen Kirkman and we have Dr. Layne.
Thank you so much for joining us.
We have Dr. Layne Martin over here, and they have a lot of exciting things to share with us today. But before we start, Angela has a message.
For anybody here who is a state leader, please go onto your page, onto the Airway Circle Professionals page. Renata is now live, so don't forget to share it onto your state leader page so that everyone in your state who is on that page in that group can watch. Thank you, thank you. Enjoy.
Of course, and I'm going to also from my phone, I will share on our Facebook group. But let's go ahead and start. I'm not going to read bios today. I just want you guys to first start by talking a little bit about yourselves. Jen, you are, I feel like, the brains and the beauty of this group. So why don't you start by introducing yourself to those who do not know you, but you keep everybody tight in there. You're the one with the glue. So
I take offense that you don't think I'm the beauty as well, but that's fine. I get it.
It's always super fun to be here, and it's an honor to be with your group. I've watched you grow, and I think it's appropriate that you have flowers in your background because this is an environment that you've cultivated a culture that everyone can like grow and bloom in whichever way that they want, and like basically just keeping the main thing. Being able to help patients with airway issues, right? Like we all have our story, we all have our personal connection, but I will touch on mine just so you can get related, because chances are is that my story is just as normal as anyone else's. As a mother, 5 years ago, I recognized that my own child had an issue, and it was a struggle working to get my patient, working to get my child as a patient. And so I ended up helping the treatment planning process, calling practitioners from all over the nation. Thank goodness Dr. Michael Gelb, now our current partner in the Gelb Institute, was a personal friend. And we were helping design other airway programs. And so, you know, I really believe that everything does happen for a reason. And even Layne reminds me of that when, you know, we're working through the things that are working well and working through things that don't work well. Which is why we keep moving forward. And so there's a series of what I would consider coincidences, but purposeful coincidences that have let me here today to lead an amazing organization of the Gelb Institute, where we train and certify general dental practices to have a greater awareness around airway and have a very simple solution. We model our model like Invisalign, where it's a plug and play system. And it's my honor to work with Dr. Layne Martin. He's been instrumental in bringing this to market, getting in patients' hands. And you guys, I can't tell you. And I feel really blessed to be able to be a big part of that. So thank you for having me here. Oh, classic, muted.
Sorry, I was muted. I made all my shares over here, and every page you guys can think of, and I already did. It was automatically for me to do to the state groups. So I did a bunch of them already, guys. Oh my goodness, somebody not muted still? No, I think we got it right. No, yeah. All right, awesome. Now, Dr. Layne Martin, would you do the honor to introduce yourself to our group again?
Sure. So thanks so much for having me. I probably know a lot of people on this. And like Jen, I don't want to say my story is like a normal one. It's probably the opposite of that. So I received a scholarship from the Navy for dental school. Amazing career in the Navy. Got out of the Navy, started a dental practice from scratch with $2,020 in my bank account in Manhattan. I crossed my fingers, put my name up on the door, and shortly after was in a great pros practice, treating celebrities, socialites. It was great. I probably thought I was hot shit. Excuse my French, far from it. And then I met my buddy Victor Avis, who I was in a study club with, and we taught together. And Victor's an incredible dentist. And every time we would discuss a complex case, he would always be like, the person has an airway problem. Next case, airway problem. Next case, airway problem. I'm like, all right, dude, you're really getting on my nerves, and it's annoying. And I thought it was kind of bullshit. But after about the 50th time, he starts to explain it to me. And next thing I know, I'm doing an airway residency with Barry Rayfield, who's an incredible airway orthodontist, great guy. And it was crystal clear that the things that we see every day in the dental practice was really the signs of a bigger problem, an airway problem. And I missed it. I missed it for 15 years as a great restorative dentist. And I think I was so sick and tired of missing these things that I walked home from work one day. I stopped on Madison Avenue and 59th Street, and I broke down in tears. I was literally crying on the corner. The next day I walk into my dental practice. I pull my office manager, Sharice, aside. I'm selling the practice, and I'm going all in on this airway thing. And just like that, 45 years old, back in school doing an orthodontic and craniofacial orthopedic residency because I wanted to fix the problem. And it was great. I was, on my way to being like, I'm going to save the world, right? I'm going to save the world and do ortho. And then I got a phone call from a friend of mine in 2019 that a patient of mine died. And it's not to make the mood somber. It's just that when my friend called, she said that Ron died. He was 55. He died of heart failure. The problem was I saw it when I treated this guy. I knew he had sleep apnea. He had all the signs and symptoms of someone with an airway problem. He snored, hypertension, acid reflux, broken teeth, collapsed vertical. And I told him to go get a sleep test, and he never went. And now he's gone. And that day I committed to becoming a diplomat of the American Board of Dental Sleep Medicine. So I went down that route. I went to Tufts, and it's great, right? Now I could put these letters behind my name, and I could tell people that I'm boarded in sleep. But in actuality, every single dentist and every hygienist and every assistant treats airway. Right? And that's a really important thing to understand, that every dentist is an airway dentist. It's not, you don't have to be a diplomat of the American Board of Dental Sleep Medicine. You don't have to be an orthodontist, because if you're making a night guard for a patient, guess what? They have an airway problem. And I'm probably ruffling feathers on here, hopefully not. But that's what it is. These people have an airway problem. Forget sleep apnea. I think the metrics are kind of screwed up anyway. So that is it. And then really, the other thing that happened was a year ago, I was jogging on the beach in Florida. I got a phone call from another friend. This time they tell me my friend Dave died. 40 years old, 2 small kids, same story as Ron. Same signs and symptoms: snored, hypertension, acid reflux, broken teeth, collapsed vertical. And at that point, I was like, okay, if it's happening in my office to these guys, it's happening in every dental office in the country. Really, the issue is, though, we need to create a paradigm shift to get beyond even dentists. And that's kind of why I partnered with Jen. I partnered with Michael Gelb, our other partners. We have a pillow company now. We have a mouthpiece, because it's really spreading the word, not just to dentists and physicians, but to the public. And really, I'm going to go into a story about myofunctional therapy, but I got trained by Sandra Coulson in myofunctional therapy because I wanted to know what was going on, and I'm a huge believer in it. I think every single person that has ortho needs myofunctional therapy. The ortho program that I was part of is really forward thinking. It's a new program in Hoboken. So we have myofunctional therapy. I mean, I'm creating a whole airway curriculum there, which is amazing. I think it's probably the first ortho program to really have an airway curriculum. So That was a really long intro. I'm sorry. I'll shut up
No,
now.
please just keep going. We're all loving it. Do you see those messages on the chat?
Yeah. So that's my story. And I think that I love what you guys are doing. I mean, Jen knows this. I don't even love the term hygienist. And I really think that it should be a different term. And I don't want to upset anyone, but to me, it's an oral physician assistant. You guys are so much more than cleaning teeth, right? I know people think that, and it really bothers me because in so many practices, you guys are the frontline defense. I mean, I know people that come to me and they're like, oh yeah, I haven't seen my dentist in years. Who do they see? They see the hygienist. So that's frontline defense. When Jen and I and Michael lecture, I want the front desk person there because I want them to look at someone's face and think right away, you know what? I think Mrs. Jones might have an airway problem based on her chin throat angle or her nasolabial angle, or if she's got venous pooling under her eyes. The whole team needs to be involved. And that's really, really important. I was in an office yesterday. A buddy of mine wants to do the program, and his hygienist is trained in myofunctional therapy. And he said, you're going to get some kickback because they've done some oral appliances and they didn't love the results and the bite changed. So when I sat there talking to this person, she shared her story, and I could tell that she was not really thrilled with me being there talking. And she kept talking about bite and occlusion. And I basically finally said, I had 2 patients, and I probably had more, that died because all I did was look at their bite. And dentistry should no longer be about teeth. I hate to say that. It's not that I don't want people to listen to this and think, oh, wait, the patient's not going to need veneers or crowns. They will. But the dentistry would be a lot more predictable if you look at the root cause and not just treat a symptom. For so long, what did I do? A patient broke a tooth. What did I do? I put a crown on it. But no one should break a teeth.
Yes.
Right? No one should break teeth. And then I showed a picture of what a central incisor should look like. Right? The length of a central incisor should be between 9 and 11 millimeters. So tomorrow, when you see someone whose teeth are worn down, their anterior teeth are worn down, they have an airway problem. They're doing CPR on themselves. So many of the veneers that I did ended up chipping because I constricted people's bites. But the other thing I said to this woman was, your teeth should touch for 15 minutes a day when you swallow. You have to breathe for 1,440 minutes a day, right? What's more important, breathing and surviving, or what the occlusion looks like? And that's really what it is, because it's the same thing. Another dentist we trained, she spoke to another a pediatric dentist and said, well, you shouldn't have the patient wear an oral appliance. The bite's going to change. And I love hearing that, because my response was, well, you know what? Their occlusion will look great when they're in a casket. Right? And I mean, that's dark, but it's true.
True.
Who cares?
Yeah.
I mean, I screwed it up for 15 years. I miss these things. And there's a great quote by Eleanor Roosevelt: learn from the mistakes of others. You can't live long enough to make them all yourself. I've made them all. I have.
Same. I mean, we all have. Just looking back, the amount of patients that I would get so upset if they came in and I couldn't do a bite wing because I couldn't get through their tongue. Like, if I had known, they can't help it. Those patients that, the lips and the cheeks, and they're just so difficult to clean their teeth. Now we know that, my goodness, those are all airway issues. How many people have we missed? Those children that come in with plaque all over their teeth because they have a tongue tie. We'll be mad at them for not brushing well enough.
Yeah, and I think myofunctional therapy is such a huge part of the process. But my lecture is very different than it was 2 years ago. Because 2 years ago, I would say I'm going to fix the problem.
Mm-hmm.
But I can't, in an adult, it's an incurable disease. You can mitigate symptoms, whether you do myofunctional therapy, you do better ortho, you give them an oral appliance, you give them a CPAP, you can mitigate symptoms. It's really kids. You get a kid before the age of 8 or 9, you could fix the kid. The problem is so many of these kids, you know, the pediatric dentist and the orthodontist is telling them, oh, you know, wait till your permanent dentition comes in, and it's too late. Think about it. You know, Michael and I talk about it. Orthodontics is brain development. Because at the age of 3, 4, and 5, your tonsils and adenoids are the largest and your jaws are the smallest. So that's when those kids are in trouble. And think about the bulk of your brain development is really by the age of 5. So it's these kids that are on Adderall and Ritalin and having cognitive and behavior issues. So many of those kids are having airway problems. It's not ADD.
Mm-hmm.
You know, and the other thing is, I was talking to a group the other day. When you see an 11-year-old that comes in and they look like they're 5, airway problem. They're not producing growth hormone.
Wow.
So it's just a paradigm shift for what dentistry is. You know, the issue is when Jen and I talk, and Michael, I don't even love going to these sleep meetings because it's the same people. I don't want to go talk to the people like you guys that are doing it. I want to go talk to the dentist that's making night guards that's not doing it. I want to talk to the 99% of dentists that were like me that kind of thought it was bullshit and never did it. That's who I want to talk to.
Yes. And how else do we get in front of them, you guys? If anybody, literally, if anybody here has a group of dentists locally that's interested in having somebody, you know, come down and talk to them, please reach out to us. We'll put something together. We are the community of Airway. We were just talking about this earlier. And we want to help grow these communities that's what we're doing with the state chapters. We want to make sure that they're, you know, we are the boots on the ground and we can help you guys grow your local communities by getting these professionals to looking at all this stuff. We have so many messages coming in. But I would, let's see. Chris said, Dr. Martin, what is your protocol for an adult before sending to Mayo or anywhere else?
So it's a great question. I think that the issue for Airway is it's 3 things. It's nasal patency. It all has to start with nasal breathing. If you can't breathe through your nose, all bets off. It's a big problem. So it starts with nasal breathing, nasal patency, soft tissue, whether it's soft palate, uvula, tongue. And then the last thing, but really what I went into ortho for, was the anatomical piece. So I think that if you see a child with an airway problem, I'm all for that kid to go right into myofunctional therapy and ortho. 100% get them in. In an adult, it's a little bit different because I don't want to tell an adult, you know what, Mrs. Jones, I'm gonna fix your problem and give you, you know, whether it's clear aligners, functional appliances, traditional ortho, and I can't fix the problem. Because if she can't breathe through her nose and then she has a soft tissue problem, I'm not going to fix her. So I'm really about proving the concept with Jen and Michael. We talk about that, of proving the concept and getting that person to sleep better and feel better, whether it's CPAP therapy, oral appliance, or a combination. And once I could prove that they could feel better and sleep better and they have good nasal patency and they can breathe through their nose, that's when I would send them for myofunctional therapy and ortho. And I think it's part of my protocol, cone beam. I love cone beam. I think it's a great question. Michael, myself, and Jen are huge proponents of cone beam. And the beauty of cone beam is this. It's best case scenario. The person's upright and they're awake. So now when they go to sleep, what happens? They sleep on their back, gravity takes over, their tongue falls back, they have an enlarged uvula, they have large tonsils and adenoids, and then that really becomes affected. So I don't rely on cone beam all the time. I think it's a great adjunct. When you hear people lecture about airway, what do they always talk about? Well, your airway is the size of a coffee straw versus a McDonald's straw, right? However, if I told you the coffee straw is plastic and I told you the McDonald's straw is paper, guess which one's collapsing faster? The larger one. So you can't always rely on looking at a cone beam or target number 120 millimeters squared and thinking, all right, that person's out of the woods and they're okay. Here's the thing. I put a slide in when I lecture now. I put a coffee straw, I put a McDonald's straw. The slide after that, I love putting basketball players and their height, because you can't decipher whether someone's going to be a great basketball player based on height. Steph Curry is the best player in the league, and he's only 6'2". So I think it's multiple things. You know, the other thing is we have like a whole protocol of how you treat someone. It's not just one thing. So it's why we invented our pillow. I got to plug our pillow.
Please do. Show us.
You're going to see it at the AAPMD, by the way. It's our release party there. Chris, did that answer your question okay?
You know,
Okay, the other thing is, the other thing for cone beam is this: it's not it's kind of a static image. So you don't know if the person's posturing forward, you don't know if they're swallowing, you don't know where their tongue is. I think it is a very good adjunct. I'm all for all of our providers. When Jen and myself and Michael lecture, I think cone beam is going to become what digital radiography is. I think every office will have a cone beam. And I think it's a great way to help kind of diagnose it. And I think it's a great tool to show the patient. But really, the only way to truly diagnose apnea is a drug-induced sleep endoscopy. It's the only way to really diagnose. Obviously, we always talk about home sleep testing or polysomnography. The only way to really diagnose someone is to basically give them some type of sedative in the operating room, have an ENT anesthesiologist there, and really see where the obstruction is.
wow. Exactly. Where is it? You know, we gotta find out exactly what we're looking at before we can diagnose and treat. We gotta diagnose it. We have 44 people on Facebook. We've never had this many people on Facebook before.
Well, that's because you had Jen on. I have to stop talking. It was really all for her.
Yeah, we love this. Somebody's saying, I just got off the phone with a mom diagnosed with ADHD, obvious tongue tie, now trying to work out what to do with her 2-year-old daughter who needs a revision. She's stuck making a decision because the doctor says no. Very difficult. Yes, give us some hearts on Facebook so more people can get to this live. Jan.
I gotta jump in. I faced 2 years of like chasing providers down. And, you know, one of the conversations that Layne had just, you know, on weekends before a presentation, we go through our deck and I got to share this story. And like, you know, I was getting ready for a presentation. I was thinking of my experience as a mom and my airway journey and what education did I want to share to make a difference. And I got done with that presentation, Layne.
Oh, you muted yourself. There you go.
So I went through this presentation and I'm like, okay, Layne, what did you think? And he's like, it was okay. It was okay. Like, and when you're trying to get ready for a lecture, like that's really not the reaction that you want. I'm like, all right. So just so you know, like I eat the biggest humble pies all the time. And I think that really helps you step into your own power at the same time. The reason why I bring that up is because I went back to the experience of taking a stand in my own confidence and what I knew that needed to be done. And when I talk to physicians and when I talk to the providers about what I was seeing as a mother, I'm like, you're only spending this amount of time with my child. Yeah, I know that you're taking these measurements and you're thinking, yeah, we can wait. But let me tell you, we're not going to wait. And I'm going to help you through the process. So whoever's watching with Facebook Live, whoever is watching the Zoom afterwards, I really want you to write down your why. Like, to the T, why are you really doing this? And if you get clear on your why and what you're capable of, you guys, everyone is practicing, everyone is learning. And physicians and providers, they want to be confident too. And their easiest way to be confident in what they know is to stay in what they know. But if you come with fierce empathy and help them understand that you guys are now a team and a partnership, and the partnership is for the benefit of your child, then it's a different kind of relationship. So if you know that your son or daughter needs their tonsils out, if you know that that revision needs to be done because you're seeing compensations and pain, if you know that they need expansion, don't stop. Don't stop, and just stay with that fierce empathy and stay in that confidence.
I love it.
And Renata, first of all, I didn't tell, Jen's making that sound harsh. I never said that I just said it could be better. We could always be better. The funny thing is, I stink at getting up on stage. I really do. I'm way better than I was, but Smiles at Sea, the first time I spoke there, was the first time I was ever on a stage. So when I gave my second talk there, it was about the first talk of being like, all right, I'm lucky I didn't pass out and fall off the stage. So Jen and Michael are amazing speakers. I just knew she could do better. That was it, which is way better than what I could do. And that's it.
Give me a raise your hand if you're kind of hard on yourself.
Right?
Like, seriously, on the
We
screen,
all are.
right?
Everybody.
That's a sign that you're exactly what you need to be doing right now.
Wow.
So the thing is this, everyone on this screen and everyone here, you guys are just trying to help people.
Yeah.
Right? Like, what's life about? Is it about being a taker? Or is it about being a giver?
Yeah.
So the people on this call are givers.
Yes.
It's the reason that we're doing what we're doing. And I think that it's, maybe you can get pushback from people in the pediatric dental world or the orthodontic world. But at the end of the day, you're really only helping people. That's all you're doing. You're not going to hurt someone. You're not going to hurt someone by doing myofunctional therapy. You're not going to hurt someone by giving them an oral appliance or, trying to do more airway friendly ortho. So I had an incident. I'm on Long Island right now, and I was driving home yesterday from Long Island to the city, and I, as a child, had ADD. I had crappy ortho. I wasn't breastfed. I grew up on Gerber baby food. So I was a sick kid that became a sick adult. And I'm a fit guy. I work out, but I had an anatomical problem for sure and a soft tissue problem. So I had in my ortho program, I got treated. But the fact is, it was still somewhat retractive ortho. They still did a little bit of IPR on me, which is not good, especially that I don't want to say I'm class 3. So from a profile standpoint, you might think I'm class 3, but I'm really more, I have a deficient maxilla.
Turn to the side again and scoot back.
Yeah.
Oh, go.
Did you see me or no?
No, move forward now. Yeah, there we go. Do you guys see the deficient maxilla? Like, give me a raise of hand if you really do see it.
Yeah, definitely. Good move putting him against the white wall too.
Yeah.
Uh-huh.
So the other thing is that I was in full brackets and wires about 3 weeks ago, and I actually took them off. And I'm going to do clear aligners, where in my ortho program, we didn't really do clear aligners. The point of the story is I still I'm suffering a little bit. I definitely snore when I sleep on my back. And I definitely have excessive daytime sleepiness where I need coffee at the end of the day. Well, I'm driving home last night. It's 10 o'clock. I'm on the 59th Street Bridge in Manhattan, if anyone knows that. And I hit a crazy pothole and like a plate. And I'm in it. I have a Jeep Wrangler and my car hits the divider. And I go, and I was like somewhat tired. It was like 11 o'clock at night. So I didn't really respond well. And my car went up on the divider, came down and hit it again. And it scared the heck out of me.
Wow.
But the fact is that it's because I have an airway problem. I didn't really respond the way I could have. And I'm really lucky, knock on wood, that I didn't get hurt and no one else got hurt. But that stems from an airway problem, and you hear that all the time.
We were talking about car accidents recently, and how, it's so awful. There's just so much marketing, I'm going to say, when it comes to text and driving. And not enough people talk about sleepiness driving or falling asleep while you're driving. And the consequences of that accident are so much worse, because whenever you're texting or whenever you're drinking, your response is delayed. But whenever you fall asleep, there's zero response. So think about that, how much more catastrophic, I can say that word, this accident can be. But I know that you guys, we all want to hear about AirVata. Can you talk to us about that a little bit?
Before Jen talks about it, I just want to say one thing about myofunctional therapy before I forget, because you brought up the 2-year-old. So I think what's happening also in dentistry is that everyone has lasers, right? And everyone's doing frenectomies, and I hear this all the time. The issue is, if it's not an infant, every single person that gets a frenectomy needs myofunctional therapy. And I really want to stress that, because the analogy I always talk about is, if you tied my shoelaces together and I walked around like that for like a year and you clip my shoelaces, guess what's happening? I'm falling right on my face. So if you do a frenectomy on an adult without therapy, they're not going to know where their tongue goes. And a lot of times it'll probably go back. So I just want to let you guys know, I am a huge believer in what you're doing. I think that it's multiple things. I don't think there's one thing that's going to fix it, whether it's using like my protocol for nasal patency is I use a neti stick every morning. I learned this from a myofunctional therapist. So I use a neti stick in morning, at night, and then I use clear nasal spray, XLEAR, at nighttime and morning. I do some mouth taping. I wear our appliance, and now I sleep with our pillow. And then I just saw my buddy Dar is on, and he's got incredible supplements too. So now it's like he's part of our team. And then with myofunctional therapy, it's like a protocol of 10 things, but it's a way to really fix it and really mitigate symptoms. So
You
all
were
right, Jen, sorry, talk about the AirVata. I didn't want to plug us too much.
No, please.
I love that you mentioned Dar, and I wish that he was, if you can, Dar, go ahead and show your screen. We would love to see your face. Dar is near and dear. Oh, there we go. Coming home from the gym, probably in sunny California. We might be a little envious. Love that sunshine. Thanks for joining us. If you guys don't know Dar's story, Renata, if you haven't had him on to share his story, then I think that's a must. I won't give any spoilers, but this is something that like really unites us. Hey,
Who is?
So here, Layne, why don't you talk about how the name AirVata came about?
I have mine in right now.
Yeah.
It's great. So when Michael and I and Jen started, it was really more a learning management system. We didn't want to make an appliance. I just felt like a lot of the appliances weren't great. They were too bulky. And I think a lot of people had a hard time getting their lips together. So that's kind of how it happened. We took Michael's lower repositioner, which was interesting because the way that Michael Gelb and I got together was I noticed that a lot of my adult ortho patients had significant TMD problems and masseter pain and jaw pain. And I went to Michael's office, he's such a generous guy. Said, come in, take a look at what we're doing. And I noticed what he does with his lower Gelb, his lower repositioner. So he takes someone that's mandible is back, they're class 2, and he brings them down and forward. And what that does is it brings their condyle to a better position, but it also relieves a lot of that TMD problems. Well, we do the same thing in ortho, where we do it with bite blocks, where we take someone that's class 2 and we bring them down and forward. You do the same thing with the functional appliances like a Schwartz or a Bionator to get a kid's mandible forward. So that's kind of how it happened. We took Michael's lower intellectual property. I took my kind of ideas with Airway and ortho, and we created this appliance. And we didn't know what to call it. We were like, all right, we'll call it Night Guard 2. And a woman that I did some CEO training with, our friend Monica, is an ARYUVEDA coach, which I didn't really know what that was. She was explaining to me, and she was talking to me about Vata, and that's kind of how we got our name. I'm like, oh my God, AirVata, that sounds pretty cool. And that's how the name came about.
So,
and here's the appliance, if you guys could see it. It's got a ramp on the upper. The ramp is actually a lot longer than this. This was like one of our first versions, but it's interesting. I showed this to a myofunctional therapist because it actually creates a good spot on the maxilla to rest your tongue. I don't know if you can see that. And then the other thing it does is it kind of locks in the mandible forward.
Mhm.
And it's really thin and it's really flexible. Like you could literally flex it like that. The other thing that I think for you guys, which is great, is the thickness. So a lot of these appliances are between about 2.6 to about 2.8 millimeters thick. A clear aligner is 0.75 millimeters. So we're really pushing the envelope. We're at about 1.2. So the vertical opening is really not that much, which means that people still can get their lips together and breathe through their nose. And then what we did was we added these buttons on the side as like elastics. I don't know if you could see the buttons coming off. But what I noticed was when I worked for an ENT, I did tons of appliances. And I did a lot of EMA and Silent Night. And the EMA and Silent Night, it's interesting. The appliance has an attachment on an upper cuspid and a lower molar. So that's a class 2 elastic in ortho, where we bring someone forward. Well, the problem is so many of those people were breaking the elastic because what happens when they open and they're a mouth breather? Their mandible rotates clockwise, it goes back. So that's why we added the little extra button here. And the elastic pops right on, and the elastics are different strengths. So here, I'm gonna show you the elastic on there.
Doris said he just got his appliance. Do you have it with you? He does. Okay. Oh, there it is. We'll let you show it in a second.
How is it?
Here, hold on. Let me put him on the screen.
Hi, everyone. Can you hear me all right?
Yeah.
Yes, sir.
Okay, so I literally just got it today in the mail. And
Did you heat it up? You got to heat it up in water.
I actually didn't do anything initially, and it's a perfect fit. Like it's so slender. I've had sleep herps, I've had the Somnomed, I've had the tap appliance. You know, I've actually been on the the webinar, and I did explain my story. You know, crashing my car into a tree type of thing. So I'm a patient, right? Just like most of us maybe. And this is brilliant. I love this appliance. I mean, I used to primarily do sleep herps. I've done a few thousand of them for patients over the last 13 years. This is much more comfortable, lighter. The metal pistons aren't gonna, people complain about scraping the inner side of their cheeks or something like that. This is brilliant. I really like it. Can't wait for tonight. I got my pillow too, by the way.
I know. So So Dar's like one of my really good friends, and I did send them a pillow because we're not really selling them yet, but I was like, all right, he's gonna give me his honest opinion amongst some other people would. So I shipped one to him. And the other thing that our appliance is great for, and I forgot that I was telling Dar this, so I wear my lower to work out in. So a couple of years ago, Under Armour came out, and Dar's working with us too on this. Under Armour came out with an athletic mouthpiece, but they really missed the problem, and they were almost kind of ripping off Michael Gelb, our partner's IP. They left people in centric occlusion. It wouldn't do anything. But if you bring someone down and forward and you open up their airway, they're going to kind of perform a lot better. Their airway will be more open. So we're probably going to do some VO2 max testing. We're going to do some stuff like that. I was just on with a couple of trainers the other day talking about it. They almost changing the face of fitness, because besides the people on this call, and Dar and I and Jen were talking about this, no one talks about sleep and fitness. And if you listen to certain people, exercise and sleep are probably two of the most important things, almost more than nutrition now. And I think that's super important to kind of understand that. But Jen, I'll let you, I'm sorry, I didn't mean to cut you off.
No, I was just going to ask everyone listening on this call and listening live if, you know, the AirVata name is really special to us, and this will illustrate it. Go ahead and put in the chat, put in the comments, an area of health, the airway and sleep impacts, like for good or for bad. Like if you think of like heart disease, you got stroke, diabetes, ADHD, ADD, chronic fatigue, fibromyalgia, like the list goes on and on and on, right?
Digestion, memory.
Yeah.
Those are some of the ones popping up in the chat right now.
Yeah, and actually someone asked a great question about deprogramming. It's really reprogramming in the morning with it once you wear any oral appliance, because so this is a tough discussion too, because when you, especially someone that's skeletal class 2, so what are you going to do with any oral appliance or mandibular advancement device, right? You're going to bring their mandible down and forward, so they're going to kind of be edge to edge. So then in the morning, what happens is the fossa is filled with fluid, so their bite's going to potentially be a little bit off. Now everyone's bite doesn't change, and that's kind of the people that don't know about airway. That's the knock on oral appliance therapy and mandibular advancement devices. The bite's going to change. So our protocol for everyone, every dentist that does an oral appliance, we teach our dentist to make a morning repositioner or a morning reprogrammer. And I learned it from Jamison Spencer, and I've kind of tweaked it a little bit. So what you do is you take Thermacryl plus beads, and you drop it in hot water, and it kind of looks like a Jolly Rancher, and you mold it from cuspid to cuspid. So people that have done oral appliances, they always get this full arch wafer, and they make the morning reprogrammer with that. The problem is, if it's covering all of your teeth, you don't know with proprioception if your back teeth are touching. So the other thing I do is I just do it from cuspid to cuspid. The second thing I do is the first day when I take a scan of the patient, I make them the morning reprogrammer that day, so they get used to it if they're really conscious about their bite not changing. The issue is, though, if you're going to do ortho on these people or restorative, I almost want their bite to change. Why would you want to leave someone that's skeletal class 2 with their mandible back all the way back? So that's what Michael and I and Dar and Jen talk about as well. You know what? We're going to bring you forward at night. We're going to open up your airway. You're going to feel amazing. But in the morning, let's shove you back and close your airway off. I mean, it doesn't really make sense, but if people don't want their bite to change, I understand that. But if you or your docs are doing clear aligner therapy or ortho, it just creates a better position to finish them in. Like I was in this office yesterday, and the dentist showed me a case of a 50-year-old male with severe wear. I mean, his central incisors were probably 5 millimeters long. He had wear everywhere. He had erosion, and they're doing Invisalign on him. And he's got now with Invisalign, they said he was edge to edge, and now he's retracting them with Invisalign. And I'm like, okay, throw the Invisalign out. I said, this is past the ortho case. Now you got to build this guy's vertical up and forward. You give him, he's got an airway problem. It's like, what do you mean? I said, first of all, he's got acid reflux. He probably has an airway problem. And now it's getting exacerbated by his airway problem of him clenching and grinding. So now he's worn all of his teeth down. And I said, stop the ortho, almost do it with restorative, because now the ortho is not going to accomplish anything. And if he did IPR, so now he's doing a retractive ortho on a guy that has an airway problem, acid reflux, and worn down dentition. So that's where we got to kind of stop treating patients like this. And if you look at the guy, I'm looking at his pictures and I'm telling him, I'm like, Doc, this guy looks exhausted. He looked exhausted. I'm like, this guy is a sick guy. You got to like get in front of this. So.
You guys are amazing. Am I muted? I can't remember. No, you guys are fantastic. Oh my gosh. I do want to invite everybody who is here and who's coming to the AAPMD. Come visit. You guys are going to have a booth, right? Airway Circle is going to have a booth. Come see us. We're going to be doing a lot of fun stuff on our booth and hanging out at the exhibitors floor. There's a lot going on. If you guys have not signed up yet, last minute, please sign up. It's in 2 weeks. The AAPMD is almost here. Collaboration Cures. So we're not.
Oh my God! Don't remind me of that. I feel like
we're not ready.
I just had a bed. We had a bed delivered to my buddy's house in Phoenix. We had a mattress delivered there because we're gonna be showing off our pillow. And I think we're having to try to like wing it of how we're getting this stuff to the meeting and setting up a bed there. But it'll be fun. People will be able to take naps with our.
Yeah. Yes.
Sign us up.
Somebody was asking to see the pillow. Somebody on Facebook was asking. That's the pillow. You want to talk a little bit about the pillow before we go? We have a little bit of time.
So the way I developed the pillow was this. My friend's an ENT, and one of my best friends, I play tennis with him, and him and I would always fight back and forth, and he'd put like someone with an AHI of 7 on a CPAP, and I'm like, all right, you can't send an elephant to kill an ant every time I send you a patient. So his protocol is someone with an airway problem either gets CPAP or he'll do positional therapy with a tennis ball or one of the things that you can buy on Amazon. But I thought about it when I was sitting there talking to him. I said, if you put a tennis ball or one of those things and someone rolls over, it's kind of breaking their sleep cycle up. They might not consciously wake up, but they might subconsciously wake up, and they might not get to that part of REM and into that sleep cycle, especially the second part of the night. So I'm like, wait, what about a pillow? He's like, yeah, but how would you design it? So I literally took a piece of paper. I started drawing it. We had it 3D printed by a friend. He literally printed a big mold of a pillow. We injection molded foam. And now it's like spiraled into this big thing. And we're trying to become the next My Pillow, I guess.
Yay. That is so exciting. Everybody.
But it really, I have to tell you, it really is comfortable, and we are really getting some good feedback. Now, I don't know how effective it's going to work for someone that's like a male that's 300 pounds, but the way we designed it was that it's almost teardrop shaped for the head. So if someone does sleep on their back, it could still prop their head up a little bit. So this is, I think, our 11th iteration of the pillow. I'm pretty sure we're like on our 13th iteration of our appliance. I probably drive our whole team crazy because I'm always like, wait, I think we can do this better. And I'm learning that, all right, I don't think it's going to be perfect, but.
So people are going to be able to purchase it at Collaboration Cures?
Yeah, we're going to set up people to do pre-orders. We're going to have a Google Doc if everyone doesn't mind filling it out, just because I really want to get feedback, but it's also not only a great product. So I was, like I said, a military veteran. We're going to basically do what Bombas Socks did. We're going to donate, we don't know the number yet, but every 15th or 20th pillow to an active duty or veteran with an airway problem.
Okay.
And then we're going to try to really employ mostly veterans. I have a meeting in South Carolina next week, and it's the same thing. It's about giving back. And I always say the military, they allow us to sleep well every night. So why wouldn't
Oh,
we give an opportunity for them to sleep well?
I
I
connect to
love
that for
that.
that.
and what you said in the beginning about, we say this all the time on Airway Circle, we want you guys to be here and to give as much as you get. It is so important for us all. I mean, we're all here on Thursday night, late at night, learning together. So please, if you got a little bit of it tonight, share this video. I'm going to leave this one open for everybody to see, because I think that this message is so important for people to hear. So share this in your group, share this with a dentist, share this with a colleague that you work with, so we can get the word out there. And I think that Jen, did you want to do a special offer for our members? What was it that you were talking about?
Oh, you're on
You're
mute,
muted,
Jen.
Jen.
That sounds great.
You're in good company.
I know, I'm so sorry. I shifted to get the link to my phone. Guys, I'm gonna put a landing, like a little web page on the chat here. And Renata, if you could share that to the network. We know that everyone can't attend the APMD, but we know that people want to be there, right? But we don't want to limit that. So we want to open this up to all Airway Circle members of getting show pricing and maybe a little bit extra cushion there, even before. So there's a landing page if you want to get the AirVata. What I was leading to is most of the time we think of patients who have all of these, like issues like high blood pressure and diabetes and sleep apnea that needs the AirVata, and it's just not true. I want to break that myth, is that it's for literally everyone. If you want to breathe better during the day, focus better at work, have a better VO2 max when you're performing a competition, or you want to lift better during sports, guys, the lower piece of the AirVata during the day is a game changer. And then you just add the top piece at night to prevent your jaw from falling back. So we believe the AirVata really is for everyone. It just helps you feel better. It's awesome. So we want to give everyone in Airway Circle that opportunity, and that landing page is how you put your information there. Get in touch with us so that we can help you.
I just shared. Thank you so much. People are asking, do you have a name for your pillow, Dr. Martin?
So we had a couple of names and we don't know 100% yet, but it's also going to be part of our research with everyone that's going to be first users of the pillow to just kind of share. I'd love for people to kind of help us name it.
Hello.
And it's fun.
Airway pillow.
We had a couple of names, we were thinking about just making it under our brand, but it's fun. And I really was passionate about dentistry for a long time, and I think I was good at it, and I love what we're doing now. And I think it's also proximity to people, right? Success is aligning yourself with people like you guys and people like Jen and Michael, and I met Dar, and we've become really close friends and working together, and we obviously, he's such an amazing provider and such a big proponent of all this, and he really gets it, and it's just kind of spreading the word. And I think that anyone on this call, any questions, I'll put my email in the chat. I'll put my phone number there. If you guys have any, kids that you have a parent that has a question, just send me some photos. Photos are great for me to really see, so I can kind of help see where their structures are. And then as well, if you have a cone beam or a Ceph, whatever, just feel free to send it.
Thank you, thank you, thank you. You guys are amazing. I cannot wait to see everybody in a couple weeks, so we can all get together and grow and talk and chat and learn so much more, because the classes over there are going to be fantastic, and the events also. Next week we have Walt Fritz. He's a physical therapist who's going to be coming talking to us on Airway Circle. And then the AAPMD, we're not going to go live that Thursday, it's the 15th, but we're going to be doing a lot of fun stuff and going live from there every time that we find somebody cool. We have a special guest for Airway Circle members, and Airway Circle and my mentor are throwing a party together. And we're going to have a very cool special guest that's going to be there at the party for those who are attending. Should I say who it is, Angela? His name starts
I
with
say go for it. Oh, I don't know.
and ends with McEwen.
No way.
Super excited.
That's awesome.
I
Yep.
know.
And our room is already full too.
I know. We have no more room. Yes, they only allow 50 people in the room. But anyways, and then we're going to start doing some Instagram lives on the 22nd. We're going to do an Instagram live instead of Zoom. So stay tuned to what's coming out. Thank you guys for coming again tonight. You guys are fantastic. You are changing the world. So super excited that you guys could come talk to us about it.
Thanks for having us.
Thank you
Honestly,
very-
I love what you guys are doing. Keep it up. It's it's a team. Takes a team to get there.
Definitely. We're all in this together. All right. Bye, guys. Have a wonderful
Bye.
Good to see y'all. See you soon.
Thank you. Bye.